Good afternoon. Welcome to today's public health meeting, although as of this moment, we don't have any members of the public, but they may arrive. Also, welcome to Dr. Kirsty Cooper, who is shadowing Matthew and joining us at the board today. We don't have any other apologies, which is good. So let us start with the Victoria, I think you're going to introduce.
Thank you, Chair, and good afternoon, everybody. Today, I'm joined by Catherine Clark, who is one of our development clinical nurse specialists, and she works in the palliative care team. I'd also just like to introduce Rebecca Deeman, who's Deputy Head of Patient Experience Complaints and Housing. She's shadowing me today. So we're doing things slightly different at the moment. We want to try a new approach to sharing patient stories. So today, we're going to share a film that was made between the patient experience team and Catherine, and it outlines the experience of a patient with complex needs at the end of their life. We've anonymised the patient using the name Oscar as a pseudonym so that we can protect their confidentiality. And so we're pleased to share the film with you. How we resource it.
Oscar lived in a supported living for people who have a learning disability. He lived in this supported living in Redbridge for over 10 years. Oscar had very supportive parents and 3 sisters. They lived in their family home that was situated at the end of the street. They would visit Oscar and all the residents and treated everyone as their family. Oscar enjoyed listening to Bob Marley music, watching the snooker championships, and his favourite food was Indian. On the 17th of November, after a 6-hour wait for NHS 111 to respond and an ambulance, Oscar was admitted to King George Hospital Emergency Department. Oscar's past medical history included a moderate learning disability, metastatic bowel cancer, epilepsy, anxiety, microcephaly, and congenital cerebral palsy. On the 18th of November, Oscar was accepted under the care of the surgeons and was transferred to Ocean B Surgical Ward at Queen's Hospital. He was subsequently moved to the Surgical Assessment Unit area within Ocean B, with a potential plan for surgery. Oscar remained on SAU under the care of the surgeons for the duration of his stay. He was cared for in a bay, and the ward allowed his family to be at his side during the day. Oscar was admitted with abdominal distension, vomiting, and progression of liver metastases and adhesional small bowel obstruction. Investigation showed the type of obstruction he had would be managed conservatively and that he was not appropriate for surgical intervention. Because there was going to be no surgical intervention, focus was switched to symptom management and referral to palliative care was made. I liaised with the Learning Disability team and the Trust to complete a joint review, as I knew this would be a complex discharge. I met Oscar for the first time with his supportive family and instantly managed to build up a rapport, focusing on things that were important to him and that his family were relieved that I focused on him as a person and not just the medical condition he had. I quickly managed to pick up that the food was one of his biggest pleasures in life, and he was currently nil by mouth and had a tube in his nose to try and relieve the obstruction. Symptom control management took time due to his past medical history of seizures and oral routes not being reliable or consistently being absorbed. I worked together with the surgeons, dietitians and speech and language therapy to work towards introducing a soft, moist diet back into his routine. Once his symptoms had been better managed, we managed to remove the tube, avoiding anything invasive. We monitored Oscar for a week and began to think about discharge out of hospital. We had difficult conversations regarding prognosis and that we thought time may be short. We involved Oscar in the conversations with his family. During our joint reviews, we completed multiple capacity assessments around discharge planning and his preferred place of care and preferred place of death with support of his family. The decision was that Oscar did not have capacity to make his own decision regarding discharge or to weigh up the benefits versus the burden, but he had stated his supported living was important to him. In our best interests, the decision was made that returning to his supported living was the best option for him. We approached his supported living management, who limited their response with us and had stated they would not be able to care for him anymore, stating that they had completed a risk assessment to conclude their decision. The reasons they gave for not being able to care for Oscar anymore were his increased health needs, his terminal condition, staff not experiencing palliative or end-of-life care, him needing one-to-one support when he was unwell, other residents being disturbed with community teams visiting, ambulance and nursing strikes, and poor experience of NHS 111 and London Ambulance Service. As a registered nurse in learning disabilities myself, working in palliative care, I felt we could not give up on trying to support the decision to return Oscar back to his supported living. We needed to work together with the home to ensure they followed support and to continue caring for him. Initially, we asked for their risk assessment, as it became apparent that they had completed a risk assessment without seeing Oscar for 4 weeks. Nobody from the home had been able to visit due to staff shortages. The learning disability nurse and I met with the Community Learning Disability Services and arranged for them to visit the home manager, as they already had a good rapport. The home manager then visited Oscar in hospital following actions from their meeting with the Community Learning Disability team. She felt more reassured after seeing him that his needs had not changed significantly, and in fact, they could care for him. We arranged an MDT over MS Teams due to the current climate and number of professionals involved, including myself, the Hospital Learning Disability team, Community Learning Disability team, the home manager and key worker, community palliative care team, district nurse, and Oscar and his mother. I chaired the meeting and all professionals advocated that the best place for Oscar to be cared for was his home of 10 years with additional support available. The home manager felt more confident that they could care for him with community support, putting names to faces in the relevant teams. I completed the fast-track discharge paperwork for funding agreement and an urgent care plan. This gave a detailed breakdown of what they may need to do to support him in the home environment as his needs changed. The ward occupational therapist completed an access visit and ordered any equipment. I supported the ward to complete the district nurse referrals for an air mattress and their involvement for end-of-life care and symptom control needs. District nurses and community palliative care team planned to visit hospital, which offered the home manager lots of confidence that this was the right plan for him. I had multiple visits to the ward to work with the ward sister and manager to ensure a smooth discharge. We liaised with G4S ambulance and arranged a daytime discharge to ensure the home had plenty of support available. Oscar was successfully discharged to his supported living. I kept in contact with all the teams involved and was told that Oscar died comfortably with his family and carers at his bedside on Sunday the 12th of February. This was an example of patient-centred end-of-life care for an individual with a learning disability and proves to us that joint working with our colleagues has great outcomes for our patients. Oscar spent 2 months at home and was not readmitted to hospital unnecessarily, as he had lots of positive experience with the community teams, particularly the district nurses, who attended regularly to review his needs and support the home. This proves that thorough discharge planning for this client group is essential to reduce hospital admissions.
Has anyone got any questions about that?
Catherine, first of all, thank you very much indeed. Thank you for coming, but thank you for making the video as well and being so clear about the process and all of the work, which sounds as if you were very committed to doing so. Thank you for that. Are there questions that colleagues have? Marta.
Thanks very much. I don't have a question, but I've got more of a reflection, because it did seem to me that the big challenge you faced to start with was the attitude in the home where he was living, and the fact that they previously had a bad experience. or probably were just afraid because they'd had no experience. So my reflection is, what is there something that we can do as an organisation to reach out to assisted living facilities like that so that they're better prepared and less resistant to actually accommodate their client group when that's necessary?
So I think we see this quite a lot, that actually supported livings and residential homes are particularly worried about having their resident back when they have a terminal diagnosis and they may need end of life care. So we liaised with the community end of life care facilitators to go out and give some training to the homes, and just that reassurance that there is services available to them. I think the reassurance now of the urgent care plan, if it's done well, it has a detailed plan of what to expect as things change and who to contact at that point. So with this case particularly, I completed the urgent care plan and I wrote everything that I possibly could think may happen for that individual so that the home could be.
Leslie, I'm going to ask almost exactly the same question, so I won't ask it again, but I will just say that I really admire your tenacity and your commitment in actually following through and allowing Oscar and his family to have him discharged to where he wanted to be. So I think that you're just a great example of someone that wasn't going to let things stand in the way of a good patient experience. To their family. So thank you.
Thank you. I couldn't have done it without the learning disability. So it's really good job work here. That's what I'm trying to do now and focus, especially with the end of life care strategy launching next week. I reach out to those site groups.
Kathy.
Yeah, well, thank you very much. I think that was quite emotional and inspiring. My question sort of builds on what's been mentioned. It strikes me that you did an incredible job of being an advocate for Oscar. And there's a bit of me sort of wonders what would happen if you hadn't been there, and I don't want to think about that. But I also think, what learning could there be from this that you could share, with many others? Because you're one person. I know you have a team, but I wouldn't underestimate your role in this. It sounds amazing. But that is a worry, isn't it? That there isn't somebody with everybody with this sort of problem who could just advocate it, put it on, and support the family. I'm not sure what would happen, but I don't know if that can be shared and translated. Really.
Yeah, I think so. Within the trust, we're trying to do lots of joint working with the learning disability team. I know there's a few gaps in the team at the moment, so we're just trying to make sure that they inform us early on if they've got a patient that they feel would need on one part, and working together. But it's just about sharing with the wards and the other departments that we are here, we're there. If we're involved early, we can ensure that these things are done properly, and you've got the time to facilitate that. But as a palliative care team, we're pretty good at last minute, if somebody needs us, we step in and we all work together. Our team's very good at that, and learning disability background, everyone will join in to facilitate what's best for the patient.
Caroline, and then Ruth, and then Catherine.
Okay, yeah, thank you so much. And so building on Cathy's thinking about the communication and the relationships. The other side of my life, I'm working with a social care provider who've got the extra care provision and what have you. And speaking to one of their heads of department, you talk about people who have got who suddenly have very complex needs and things like that, and immediately they're saying, we haven't got the same staff, we can't do this. Is there a way to strengthen that communication and that partnership, perhaps, so that more people can benefit in a way that Oscar was?
So I think we are trying to work very closely with the community learning disability teams. They know the person best. They go out sort of weekly, sometimes maybe monthly if they're not needed. So trying to work with them to share about positive experiences of end of life care and what is available in the community. So it's just about strengthening those community relationships. And I think it's the same for every sort of area at the moment. It's just trying to acute and community trying to merge together to prevent people being readmitted to hospital unnecessarily. So like this case, community learning disability team, they had a rapport with that particular supported living. They already knew the staff, so rather than new faces coming to say, well, why can't you take that person home, they went out and actually had a relationship already, and they, you know, facilitated that. So I think it's just about strengthening those relationships, sharing our skills.
Also starting to work with the palliative care team within patient experience. So we're starting those conversations with the lead nurse. So would include that. I think there's a lot around standardising some of the availability, and make sure that information gets out to some of these supported living and care.
Ruth. So I was going to ask, so during the admission, very appropriately referred on to the palliative care team, being this patient's condition was known beforehand, not the obstruction, but his condition was, and this was a terminal illness, was he already known to palliative care before then? No. Was there an opportunity for him to be known before that time?
I think he didn't have any complex unmanaged needs before admission to hospital. So I think it made it difficult because he wasn't known to any of the services. So it was a new plan to try and get him back home and bring all these services involved when we knew time was short. So I think normally, you know, if the GP or the district nurses, if they were known to them, they would refer on to community palliative care. So not everybody needs community palliative care input. It just depends on the complexity of you know, that individual. But certainly in this, you know, client group, we would expect really an increase in people recognising that early involvement of palliative care and advanced care planning, to have these conversations that we had to have on this acute admission when they could have been done months before. You know, this is where he would want to be cared for, capacity assessments to, you know, we had to do all of that on this admission, which is, it can be distressing for the family as well. They're really supportive family, but if they didn't have that family around them, it would take a lot longer to establish what the best interest of that patient.
I just really wanted to reiterate that we diagnose people in their palliative stages late, not just elderly, lots of patients. And I think it is an area that we're starting to think about how can we do this. Because this is quite a short period of time, an intense input. And if you think you were doing that with 40 or 50 people, we just wouldn't have the capacity to do it. So we need to do it further out. But we recognise that's an area.
Okay, thank you very much. As I said, thank you. And I think you've heard from other members of the board how impressed people are with, you know, and don't downplay your work and your advocacy, because it sounds as if it did make a difference. And I think, as people have said, what we need to learn from that is how across the system we need to make sure that there are more yous and there's less need to advocate in quite the way that you have to. But thank you very much indeed for that. It's a very good start to the meeting. Thank you. Thank you, Victoria. I'm sorry, but I'm getting seasick. Honestly, I feel ill. Yeah. It's very, very disconcerting.
No, I'm sure.
Yeah. I'm really dusty. Turn that off.
I mean, it's not, I don't feel sick looking at you lot. Okay. Let's continue. That was very good, patient story. It's very impressive. Good. So apologies, we only have Linda Vandenhender actually as our apologies. Directors' declarations of interest. I'm presuming nobody has anything they need to declare with respect to anything on the agenda today. We've removed the whole register of interests from the papers. They are available on the website if anybody wants to look at them, which brings us to the meetings. The minutes of the previous meeting on the 2nd of March. So I will go through those a page at a time. Page 1, page 2, page 3, page 4, page 5, page 6, page 7, page 8. Thank you. Page 9, page 10, page 11, page 12, page 13. That's the end. So we can take those as a correct record then. And if we look at the action tracker, the first item is due at the next meeting on the impact, the Project Snowball evaluation report. We received the trajectory with respect to urgent and emergency care performance. So those are the only two actions linked to those minutes. Are there any other matters arising? No? Okay, good. So just a few things from me. First of all, Matthew covers quite rightly in his report the impact of the strikes that have been taking place since we last met. I just wanted to reiterate the point that he makes. Firstly, that we do, of course, have considerable sympathy for our staff, the very difficult decision that they have taken to undertake strike action. And we've worked quite hard to maintain good relationships with our staff during this period, not only of junior doctor strikes, which of course we have been impacted by directly, but also this period of uncertainty and other industrial action that has been taking place as well. But it is also undoubtedly the case that the strikes have had an impact on our patients that we have had to work quite hard to mitigate in terms of uncertainty, but also very practically in terms of cancelled operations and cancelled procedures. And this has just put an additional pressure onto our patients, pressure onto staff in reorganising and working to cover those periods, and of course to our ability to meet the targets by which we are held to account because of the challenge that that action has brought. And it isn't sustainable, and I know that we all hope that there will be appropriate negotiation and agreement on something that people can feel confident about, that will enable us to go forward and continue to look after our patients and hit those targets in future. We're also, of course, in the that time of year in the NHS when we are planning operationally for next year, but also planning financially, and we'll talk a little bit more about some of the details of that later on this afternoon. But it's obviously the case that next year financially is tougher than have been previous years. We're moving away from that additional COVID funding, and we're facing, of course, alongside that, considerable increases in demand, and we're being expected to plan on the basis of achieving financial targets, which at the very least, I think it would be fair to say, will be enormously difficult to deliver. And we've had some, I think, very helpful conversations across the system, but we've also had some perhaps less helpful interventions from those at the centre about what they're expecting to see in our plans. Our task, of course, is to ensure that what we are planning is deliverable for us and our patients, not just something that looks right for others. I've had some really good activities since the last time that we met. Matthew introduced me to the recently formed Shadow Executive here, which, if you remember, is an initiative to enable staff from all sorts of backgrounds and all sorts of different parts of the trust to be able to feed into the decision making of the executive, particularly those who are underrepresented at the top of the trust. It's a great initiative, and they were a really interesting group of people, and it's good to be able to talk to people like that about what the board does and who you all are, which I did as well. Last Monday, Janine and Matthew and I had a very lovely cream tea. And before we laid into the scones, we took the opportunity to award long service certificates to staff. It was a really lovely event. Staff are in real celebratory mood when they come to the event, bring members of their family, and to be able, on behalf of the board, to thank them for their service and everything that that means for the trust of our patients is a really, really nice event. I also was able to meet back in April leads of our local Health Watch organisations. This is always, I think the Health Watches in this part of the world are enormously positive and keen to be involved with us on a whole range of issues. We talked about the work they've been doing on maternity. We talked about things that they're contributing to in terms of learning disability. And it felt like a very constructive, challenging, rightly challenging, but constructive relationship that we have with our local Health Watch organisation. So I was very pleased about that. And then finally, the reason I was late this morning to the beginning of the governance visits is not my fault. It is the fault of the King, because we were at KGH as part of the judging of the coronation decorations in various different parts of KGH. The equivalent happened here at Queen's yesterday. There is a phenomenal amount of effort and really interesting things that have gone into decorating a whole range of areas for the coronation, including working with patients, working with local schools. In one ward, they talked about the way in which they were using the coronation and the pictures that they got to talk to our international nurses about the history of the royal family and what were the big sites that were going to be involved in the coronation. So regardless of your view of the monarchy, and I'm not probably the greatest fan around the table, nevertheless, it was a really good example of using that event to bring teams together, to have a bit of fun, and to that there was a lot of very good feeling amongst staff and patients about the decorations that had happened. As I understand it as well, earlier on in the week, cakes were judged, and on Saturday, cupcakes and scones will be consumed. So all in all, a very lovely way to run up to and to celebrate the coronation. Matthew, I bet you haven't got as many cakes in your report as I do.
So, yeah, a couple of things I'll call out, and I'll refer mainly to stuff in the report this month, but I think there's some important things in there. In the first place, the government has set trust the target of reducing people who waited 18 months on patient waiting list to 0 by the end of March. And I just wanted to give a shout out to Fiona, to Joyce, to Leah, Mamalish, Simi and others who've been involved in us getting that 78 weeks down to 0. There's only 3 trusts in London that managed it. One of the others was where Fiona worked before, so there was a common factor there as well. But we were able to deliver that 0 there, and that is important. It's important because it's a target. It's important because of what sits behind that target, actually. And what sits behind that target is people who are sitting at home waiting for procedures now, are waiting to see someone about something they're worried about. And it's really important in the context that we can get people seeing the treatment. The next goal is 52 weeks. So that's kind of in our sights, but it's also really important that across North East London we make sure we don't end up with a bit of a borough by borough lottery on where people wait. So we have people who wait in our patch for much longer, perhaps in the Barts and Homes patches and vice versa as well. So we've been working with colleagues at Barts, looking at some of the specialties where we think we might be able to do a bit more together to try to make it a fairer waiting list across North East London as well. But I just wanted to start by highlighting that. It's also worth bearing in mind that of the 65,000 people who are sitting on our waiting list at the minute, that's gone up by about 5,000 because of the strikes and Easter. Of those 65,000, around 5,500 of them are waiting for a procedure, either as an inpatient or as a day case. Actually, the rest of them are waiting to be seen as an outpatient, or waiting to be seen as something of assessment or so on. So when you do hear about these waiting lists, the thing to have in mind is not that these are all people who are sitting at home waiting for surgery. These are people who are waiting for us to do something with them on the whole. But this isn't all about faith and capacity. Lots of this is about how we manage outpatients and how we look at our ways to make sure these people get seen and treated. And the surgical hub at King George was really important in that. I think Kathy and I were looking at their respiratory wards this morning. We were talking about the importance they have on their clinic rooms where they do pleural drains, and how in previous years they've had patients waiting for beds put in there, which immediately stops us being able to do some of that activity that keeps people out of hospital. In the same way, protecting the surgical bed base at King George Hospital has allowed us to really motor through these backlogs. Actually, it's been a fantastic facility, one of only 8 accredited surgical hubs in the country. And a shout out to Guidey, who does some really important work in there as well. But it's been a big development for us, actually. We'll increasingly play a part in helping North East London get to grips with their waiting lists. We've also seen cancer improving. Our backlog performance against people who've been over 62 days is the most improved in the country, and we're hoping to go up that 62-day backlog this shortly as well. And I've also put into the pack some information on radiology. We had a really big problem with radiology. Where last summer we found thousands of patients who should have been on our waiting list and weren't. And we've now actually managed to work our way through that to a point where we're now fully compliant with national standard on radiology. And there's been some super hard work done. There's been some changes in some of these areas. But that's been a huge piece of work actually to really get to grips with that. So there's some very good work going on there across a number of teams, and I named a few of the more senior people involved. But lots of this is happening very locally. Lots of this is really good work between clinicians and their support teams and local services getting these things done. I mentioned Easter and the junior doctor strikes adding 5,000 odd to the waiting list, plus other impacts. I won't repeat what Jackie says other than, we need to really focus on maintaining the goodwill of our staff. And we're in an environment at the minute where people can choose to work in other industries, and some are choosing to work in other industries. Actually, it's really important that we are a good employer, and that we as a service actually employer we're committed to this for the future as well. So I'd echo what Jackie said about we really hope that there's some resolution to this, because it is damaging our ability to do what we're trying to do. It's causing us problems. Urgent and emergency care. Pleased to say, having given some of the public comments I've made before, that our April performance, I think, has probably been the best since I came into post. Lots of that, thanks to Caroline, to Kareem, and to the ED team actually, and Acute Medicine for opening up our big SDEC, is the technical name for it. SDEC is same day emergency care, and it's where you offer people access to specialty treatment or emergency treatment. That means that they can be seen and treated and sent home in circumstances where previously they might have been admitted. Now, we are a trust that tends to admit people to treat far more than many others. And we know from looking at North East London data, if you live in our part of North East London, you're far more likely to come into hospital for conditions. If you lived in, say, Tower Hamlets, you'd be treated in the community or within primary care for. So that this SDEC for us, it's probably given us more of a performance boost than we thought. And I think that's partly because it's allowing us to get to grips with some of these pathways where we can work around that. There's probably more we can do about ambulatory care, same-day care, infusions, etc., to build this model. But thanks to Caroline and the team, who've been really focused on getting this into place, and Louise and the team at King George are really working on the SDEC model there. And once we can get them more support, some senior cover, I think they'll really start motoring shortly as well. So that's good news. Long mental health waits do continue to be a real issue for us. I've been on about this for a while, and we'll continue, I think, to raise this. The average length of stay for mental health patients in April in our trust was 17 hours, average length of stay. That was 19 hours at King George. And that remains a really big problem. And I think King George, March and April seen pretty much the highest numbers of mental health patients since we started counting this as well. So that's a growing problem for us. And we've also heard a patient story there about people with learning disabilities as well. We currently have a person with learning disabilities who's been in our emergency department for 380 hours, which we think is a record for the trust. I don't think we've ever had anyone left in ED for that long. The ED team, working with support from NELF and others, have done a brilliant job of looking after this patient. But we've had multiple assessment point providers who've been unable to offer anything for them. And I think it's a really worrying situation that's happened a number of times. Now I've mentioned a number of LD patients. I think the last one was 244 hours. This one now I think will be well over 400 hours by the time they go home. And while it's great that our staff are doing such a good job of looking after them, I think it's entirely unacceptable as a system. But there's no alternative for someone with complex learning disabilities that wants to be in the emergency department for a horrible amount of time. So that's grim and something we'll be continuing to escalate. And then once this is over, I think we need the system to get together again and think about doing something fundamental is whatever we're trying to say. And I should say, you know, NELF and others have been working very, very hard to support us with this, so that I'm not attributing fault to this. This is a really complex case, but we need to get our heads together and figure out a different way to do this because it's not working. Money is going to be in. I think I was at Bart's word yesterday. I think we used the word difficult challenging a few times, and I think we'll use it again today because the financial context for us, as with our partners, is hard. I think because we've been in soft war for a while, we've had a bit of a run at this actually, and we've been really focused on taking out costs. I think it's notable looking at our bank and agency staffing costs. I think we've reduced that by around £11 million in the year just finished compared to the previous year, but that's from a very high level. I think it was from around £104 million, around what we down to now,
just over 10%.
So just over a 10% reduction in what we're spending on bank and agency. But you can still hear that that's a huge sum of money that we're spending on bank and agency. Obviously, banks are very different proposal to agency. We're about to start introducing, and we have been introducing some much harder limits on using very expensive off-framework staff. And Catherine's provided us some good data. I think around half of these off-framework requests come in on Friday and Sunday night. There's lots of last minute stuff, lots of lack of planning, and we're really tightening up the rules around that and hoping to entirely eliminate that shortly, because that allows us to save money, and that's money that we don't have to take out of elsewhere and invest in frontline care. And then there's a couple of pieces in my report about two employment tribunals, one where we sacked a doctor for sexual harassment, member of staff, and that was upheld in the tribunal. We're very pleased about that because I think we've made clear to the staff that we want to take a different approach to sexism and other forms of discrimination in the workplace. At the same time, we had a really disturbing tribunal report of an incident, I think in 2020, about racism in our services and racism experienced by staff. And although, as I said, 2020 is still very much a current problem in that and other services in the organisation. So that's going to be a really big focus for us as we really seek back to staff survey results, which we'll do more about today, to make this a place where people are better able to work without fear of discrimination because of who they are. So thanks to the team who've been involved in trying to support us with the efforts, but there's a long way to go. So I think that was probably everything else.
Thanks, Matthew. Are there any questions or comments? Leslie?
It was really just a question about the patient you spoke about with learning disabilities, and it's sort of similar to the issues that we've had with staff with mental health difficulties that we've also had over long lengths of time in ED, and we've said it's just the wrong place, and appreciating that NELF are doing what they can do, and we've said here it's a kind of system issue. That are we getting anywhere?
It doesn't feel like we are, and I think if you look at the data, I think that the data for March and April is the same, pretty much the data for September, October.
Yeah.
That said, I know there have been a number of new services open, but I think demand is
we were talking about this just this morning in between Sceptres and Orbs and Crowns. We were talking about this, Louise, and you told me some quite sort of shocking figures for March.
Yes, I've got them written down. So KVH had 200 mental health patients for its ED in March. That's the highest we've ever had. The total time in ED was 3,170 hours, and the average length of stay was 16 hours. And we had 14 patients who spent greater than 36 hours in ED. It's really important.
So this is, I mean, I think the only conclusion we draw from this is the one that Matthew drew, which is that whilst there is a lot of work going on, there's more, it's a test of the system. Yeah. And we need to continue bringing people together to try to solve that. I think.
Just a quick one, because I think we'll probably come back to it later in the paper, but was struck by the comment in your report about 290 nurses coming from one place or another over the next few months, which feels, you know, we've got a lot of nurses, so that's not a massive percent, but it's a significant number. And I'd just be interested that as we do that, we really do make sure we don't have the expensive agency as well. And maybe there's something to come back to, but I just think we need to ensure we get the real benefit from that. Although, of course, in that time some will leave, and you know, it's natural turnover, isn't there?
Yeah, so we're doing a couple of things. One is the kind of control measures around the use of our framework, because I think sometimes there's a risk that booking to certain numbers becomes reflexive rather than deliberate at certain times. Although I think actually with the nursing hub, I think we're pretty good at avoiding that. I think we're very good at nursing security actually. And the overseas nurses will be a great part of our recruitment strategy, which is about reducing this dependency. I think predominantly from the Philippines and India, as ever as well. And I think it's interesting to recognise, I think almost 10% of our staff are from the Philippines. It's really striking at Long Service Awards to talk to the number of people who came over, and we're talking about their batchmates who they came over with together 20 years plus years ago, and they're still working here. And the feedback is that actually we're a very welcoming trust. And if people aren't aware, the Philippines trains nurses to export nurses. So this is one of those systems from which you're not bringing people out of their own healthcare system. They very deliberately train, I think, around 4 times the number of nurses they do each year, so you can do this in an ethical and sustainable way. But yeah, so it keeps our pipeline ticking over, Catherine. We'll reduce some of those costs, and we hope to be very welcome to join our international partnership.
Ruth, and then Mahbub, and then Sue.
So my comment was going to be around the junior doctor strikes. I was quite surprised that 5,000 was added on with what was 5 days of strikes, with there not being a current end to that. I mean, it's gutting, isn't it? Looking at the chart and seeing how it was going the right way, and how 5 days has put us back to where we were, what, 9 months ago, when such good progress was being made. Clearly, the concern is that it's going to keep now going the wrong way if we're going to get more strikes. How do we benchmark, though, across NEL? It was 5,000 kind of what we expected. Did we over cancel compared to other rails? Is it? And the trust is in a really difficult position, because if the strikes don't have an impact, it reduces the influence of the strikes, and then we're going to get more of them, frankly. So there has to have some disturbance if we have a responsibility to our patients to care for them in a timely manner. So how are we forecasting that with more coming inevitably our way?
So in terms of the impact, although it's 5 days, it's a multiple of that really in terms of its impact on the services, because the activities that we cancelled during the strike days, we didn't have to rebook those same patients, which displaces a further set of patients. So 1 day strike activity loss is kind of 3 days worth of activity basically, because you'll lose that day, you get the rebook day, and then there's the people you can see on that day. So although it's 5 days, it's the equivalent of more like 3 weeks worth of activity. So it's difficult in that context. Lots of these patients, of course, will be non-admitted patients, so there's ways we can get into them and try to keep the numbers down as much as possible. And benchmarking wise, we did share extensively data with partners at Barts, Thomas and elsewhere on cancellations. I think we were very sensible. I think we were better at the second strike than the first one as well. And because we'd learned from the first one, actually, there was lots of services we could maintain, and the amount of activity we took down predominantly outpatients. I think it was about 2,500 outpatients. Appointments, a very small number of surgical inpatient procedures in the case. So if it continues like this, I think roughly those numbers, I think a strike day equates roughly to 1,000 odd on the PTL at the minute. I don't think we'll be able to get it much tighter than that, to be honest with you. And if it continues, I'd expect to see the PTL effective going forward.
Yeah, thanks. Just I guess as a reminder that the business case that was approved for recruitment of additional overseas nursing staff has got real robust benefits realisation around that. So numbers in will equal numbers going out, and saving and expense pay for itself. And we're going to have to keep an eye on that, see if the business case is realised when it lands in September. About us going off, us no longer using off framework agency staff there. But there is a sort of system-wide issue around that as well, isn't there, whereby if we're pushing in a particular direction, we've got to have Barts and Homerton also thinking about doing the same thing at the same time, because it's about managing that wider labour market as well. And I wondered if, whilst it's Matthew, your report, if between yourself and Shane, have got any thoughts about how that collaborative, I'm sorry I missed the meeting yesterday because going with no AV there, but that sort of viewpoint. I know it sounds like a brilliant building. Sorry.
So I mean, Barts doesn't have the problem with operating our agency. I think we use a lot more of it in Barts structurally, and I think that has been more of an issue. Whereas we certainly are working collaboratively on bank rates, both about what's on our framework agency rates and our bank rates. And I have to say that Daniel Waldron, the CPO at Barts and the teams there have been really transparent in terms of where we are with rates and recruitment and so on. North East London, I think, is a big outlier as a system for its spend on temporary staffing. I think we spend more than most other ICSs by the country mile. Really? Yeah, and I think we're quite a marked outlier on that, and there's always been a big market for it here, which is influenced also by the way the Essex system works as well, where it's also a really significant cost factor. So I think only by the trusts working in lockstep can we really drive some of these costs. It's a big area for us to save together and to improve the quality of our substantive.
I mean, yeah, we picked up some of this yesterday, and it's referenced in the next report, which is a temporary staff and workforce book streams very much in scope. And I think, to be fair to colleagues here, and Catherine's clinical leadership gone a lot further, I think, on sort of some of targeting to kick off framework high cost agencies, and actually there's some lessons to learn at Barts, which we discussed yesterday about perhaps getting into more in that space. That proportion, as you say, it's not quite the same issue.
Yeah.
Sue.
Thank you. I'm taking us back to the mental health question. I've been ruminating on that. There's a lot of evidence in our papers and in the activity of the Trust around the collaboration between Barts and Homerton and the benefits that we're deriving through that around unwarranted variation. I just wonder whether we need to put equivalent scales of effort at all levels of the organisation into equivalent collaboration with mental health and community services. Because today in our visit, we saw opportunities where the community services could help with people coming out of the hospital. We've talked about the mental health challenge. And it feels to me like that concerted effort and project approach to bringing Barts and BHRUT and Homerton together, could we be applying that to collaboration with mental health and community with the specific targets of addressing these things? And have we thought about that, and how could we take that forward?
I think it's spot on, really, Sue, in terms of one of the things we need to look at. And I think one of the issues with the provider collaboratives that have been set up on the North East London basis is there's probably closer working between than there is between acute mental health and community within our patch. And I think it's it's interesting. We talked to the team at Homerton. They talk about the real strength they get from having ownership of primary care, community care, etc. within a single trust. And Barts do the one based in the UK. So I think the relationship between NELF and PHIT is probably a lot more. And lots of the community and mental health patients, there's often quite a lot of overlap at that. When I was at Oxley's, I think a third of the patients in the diabetes team were also under Oxley's for mental health treatment. Well, so it's these same group of people with a number of long-term conditions that require management.
Yeah, so I think you hit the nail on the head though. So a lot of the actual effort has gone in making the acute provider collaborative work. So the three acute trusts working together, as you can see in the next paper, etc., etc. Paper is completely silent on how the APC works with the mental health collaborative community, and that's a space we need to get into. There's also something about how this fits in with kind of evolving integrated care system architecture, whereas those collaboratives are all in different places. So we also need to be ready to be a partner, if that makes sense, at both ends of that scale.
Yeah, it feels that we have warp and weft, and we're working really hard on reinforcing one, and we're not working hard on creating the other. So our fabric is flimsy.
We have, of course, an opportunity next week today, when we have the North East London ICB NED sessions, and there are various things that we have talked about in both boards where there is sort of system implications and where we might have something to say about how the partnership would work and where the benefits might be. And we will be putting together just a note for the NEDs that are able to take part in that event next week, just to remind people about the things that we previously talked about, where it would be good to have a system focus, and NEDs might want to raise that as part of the groups that they'll be in, etc. So you're chairing the group, aren't you?
The one about the interface between mental health and I wonder why.
Good. Okay, anything else on those reports? No, thank you. Thanks, Matthew. So now we look at the collaboration update, and Shane is going to introduce.
Yeah, so I'll be relatively brief because I think hopefully the paper's fairly straightforward. It went to the Barts board yesterday, was well received. I think it'll be the view. So the same report here, and I think one of the key points here is not just trying to combine the work of Barts and BHR and put it in one report and say that's it. It's about where's the value add on top of working together. We've discussed a number of times here, so just to reinforce that ethos. We've got an update on both the Acute Provider Collaborative and the Integrated Group working. So on the APC, first of all, you can see the work streams there on page 870. I think some good progress in 22-23. We've got a number of examples which I won't read out across planned care, critical care, cancer, and spec services, where I think we can demonstrably show benefits of working close together. I think that Matthew probably agree that Homerton have become increasingly closer to us as part of this partnership and very keen to work with us, particularly where it makes sense on patient pathways and patient flow. So I'm just going through a review for how this will look for 23-24, and at the same time, as I think I've reported previously, establishing clinical leadership roles for the networks across the 3 acutes across North East London. So thanks to NAPSA, we work with colleagues at Barts and the Homerton on this, but that sounds easy and just move on, but actually that's quite a step, I think, around genuine clinical collaboration, which will then help us drive up standards, reduce variation, and therefore make a better deal for patients. I think we can go for that's a quite positive step. On the integrated group, lots of good work going on there. You can see the touched on temporary staff. That's a huge part of trying to do big programs in there as well. So we had discussion yesterday about is this ambitious enough? Is it too ambitious? Somewhere in the middle, and it probably depends how you look at it. But I think what we're trying to illustrate is that within this there are some huge items here. So the digital capability workstream on its own obviously largely encompasses the rollout that we'll do here. Looking at Nick, that's a huge project just on its own. So yeah, there's quite a good balance here, I think, of practical things, not too many, but things that have plenty of depth in them. So good work on the sort of thrombectomy piece. The REACH service, just spoke to Karim about that this morning. That's looking to expand further post the pilot. That's really positive. And then, as I say, aligning temporary staff, doing more around pay rates, working closer together, which I think will have quite a impact across North East London, but also probably quite difficult to implement. Therefore, just take the time to get it right. So I think, in summary, good progress across both the APC and the integrated group. Here the reports here to note. Happy to take any questions, Chair.
Thank you. Are there any questions or comments on that? What's Kathy?
Just a quick comment, which is probably given the size of the system, is probably pretty unhelpful. But just thinking of the last conversation, yes, start from a negative. The last conversation about the liaison with mental health. In some systems, they actually put the acute and the mental health and community in a single provider collaborative. You know, perhaps systems that don't have quite so many organisations, but it is, you know, you just kind of wonder whether or not it's worth even reflecting on. I don't know that it is, but this is what happens in some, and I think it is quite helpful because you've then got everybody working together on the same things.
quick response to that would be, I think I understand exactly what you're saying on the system. I think the view we've taken at the ICD level was let's have the collaboratives, let's get them established, get them working, quite what we do in our space. And I think to be fair, there's some work for NELF in that space. Down the line, who knows?
Yeah. And much of that work between those different services actually happen at place. So I think what we're describing is almost the horizontal integration across North East London. Yet where we can make a real difference in terms of creating new models of care that can actually have an impact in terms of keeping people out of hospital, for example, will be at place. So we are a partner at each of the 3 place-based collaboratives across the H&R. In terms of the three boroughs, and we're starting to work with those partners to do some really good work. Louise has picked up the lead role for that in Redbridge, in her new role, and we're now just really starting to think through how we can bring to life some of the things that we've been talking about in the last year in that partnership approach into real impact in terms of the residents of those areas.
Any other questions? One of the points that was made in the Barts board yesterday about this, and I think it was made by you, Kathy, so you may not want to make it again, so I'll make it because it was right, is that this is a good report, and it probably has more meat in it than previously, which I think demonstrates the way in which the collaborative work is beginning to bear some fruit. But what it doesn't enable us necessarily as boards to do is to really track the progress of the items that we have identified as being the priorities. And we will give some thought to how we can ensure that the boards are able to monitor and assure themselves of that progress, perhaps a bit more clearly than we've done up until now, where it has really been about quite a lot of process stuff about setting it up. But now I think we really are going to be able to actually measure and see which programs are going well and which perhaps need a different approach.
Yeah, I was going to say that as part of that, myself and Nick are meeting our counterparts from Barts, so Adam Sharples and I forgot his name. Yeah, that's it, tomorrow, to sort of work through about the elements of it that will land in both our finance and performance committees and how we can get oversight and assurance from that way and kind of work it out and see how the best way of doing it is and try and replicate it across other committees. So we'll see how it goes, but it's a really important thing to do, isn't it? Because at that high level, the ambitions are really good, the relationships are brilliant, fantastic, and it's knowing that then throughout the rest of the organisations, both organisations, but deeper down, is this an ability to turn those plans into deliverables that are making a difference? And where I think Barts has got an advantage over us is that they've got a mature, embedded, pretty effective central PMO as well. We're developing ours. I met with our colleagues who are working on it this morning. So I think we'll be leaning on Barts to try and help to have that programme management brought into sight for the 2 respective fix. Shane's nodding, so
Yeah,
tomorrow I can go into the meeting and say Shane agreed to this. Yes.
I think exactly, but anything we can do practically, and Nick and Harlan are well advanced on some of this across a range of things. It's also grounds up for collaboration that adds value.
Yeah. Thank you.
Good, thank you for that. Let's move on then to the quality and safety section. We start with the reports from the Quality Assurance Committee. And can I just say, is this the first meeting, Linda, where we've had the new committee reports with the assurance groups in them?
All of them, yes.
Yeah, all of them. Yeah.
All of them.
I think it's a really good development, actually. So well done to the committee chairs and the work that's gone into that. Probably also worthwhile saying, though, we have been meeting and thinking about the quality of board papers, and I am coming to talk to the exec team in a fortnight about that. So that'll be good.
Looking forward to that.
Anyway, Kathy.
Yes, thank you. I think we've been doing this for the quality assurance part of the strategy. So that's good. So I wasn't going to say too much actually, because it is quite a comprehensive report if you have a look at that. I just want to throw out a small number. The first one I think to mention is we did take sort of partial assurance, I think it was, on the CQC inspection update and also the maternity survey. CQC did the maternity survey, and we'll bring that back in this month to the next committee, because we just needed to see sort of action plans and progress against plans. The next one I was going to mention is the digital dictation serious incident investigation. Again, we had a good look at that. We were fairly confident there's pretty good systems and processes need to be put in place that don't rely on human factors. So we again will bring that back, because I don't think we've got full assurance there on that one. I did want to call out the other bit of the report, just because people will be anxious about it, to just know that we were assured with MANTA's help around the employing doctors with incorrect registration, that I think our worry was that if we'd found one, was this the tip of a very large unpleasant iceberg, and it turned out not to be the case. I just wanted to particularly mention that. And then the quality and safety strategy and the learning from death are papers within the board agenda, and it was good to have the quality and safety strategy. I think the first one really, I think, was fair to say. So I think that's good work, we felt. But the rest is as written, and happy to take any questions.
Shall we use that then as an introduction to move on to the integrated quality and safety report? Catherine?
Thank you. So just picking up the quality and safety strategy, that's absolutely right. This has been a strategy long in gestation, but it is here now, but we recognise that it will probably need to change in the next year or so because of the introduction of PISA. So it's written in the knowledge that we'll probably have to do that. Obviously, you've got the paper. There are a few things that I just wanted to raise to the board really. Firstly, the introduction of the Incident Oversight and Learning Group. Mamta asked us to do this when she joined the organisation, and that's now been in place for a couple of months. It's excellent. It gives us an opportunity for lots of people to come together to discuss serious incidents, where perhaps there's a bit of a discrepancy about whether people think there are serious incidents or not. There's a good attendance on a weekly basis, and I think that that's really strengthened our decision making around serious incidents. Continuing with serious incidents, we still are really pushing the local teams to complete their serious incidents within a time function. So we're continuing with that work, and we had quite a long discussion about that at exec earlier on. The number of complaints that we're getting are going down, but I think again the teams are struggling to complete those within the required time, and the number of actions that are being requested has extended. So we haven't had extensions for a long time, and over the last 6 weeks we're getting 2 or 3 a week. So I think they're probably struggling a bit. We've had a PFD in March and one again in April, as detailed in the report. And the report says that we have a risk rated at 25 around the radiology backlog. That has now been cleared during April, so that will be reviewed and obviously significantly downgraded. But it's just the timings of the reports and particularly. And then just the final bit that I want to note is that during COVID we lost a lot of our volunteers. So we're really working hard on how we get new volunteers to come and support the wards and the organisation. They're really valued as part of the ward teams. But we're also working with a greater number of young people, particularly volunteering experience, before they can access ongoing education and training or come to work for on apprenticeships. So it's a slightly different approach to the approach that we've worked on. Happy to take any questions.
Questions or comments?
Thank you. Catherine, the group that you referred to, the Incident Oversight Group, I know it's longer than that, but that's the words that I remembered. Will that group be responsible for monitoring the implementation of action plans following serious incidents? And if not, where will that happen, that
So
we
that-
get that assurance?
Okay, so that's the process that is in place at the moment. That goes through the serious incident group and is signed off with the ICS. This is about, and that will change during PISA, but that's the current process. But what we have historically had a position where there were roundtables held predominantly with the people involved in the serious incident to decide whether it's a serious incident. What this gives us the opportunity to do is a much broader number of people from a variety of disciplines, but not necessarily the same speciality, can look at all of the incidents and decide whether they're a serious incident or a red incident or not an incident at all. So I think there's lots of learning going on in that environment at the moment. People are having active discussions that they perhaps wouldn't have had before, and also all of the clinical staff involved in the incident are coming and presenting, so we've got a much broader range of people presenting those, so it's really much better.
Did you want to say something?
No, sorry, I was on a different thing.
Ruth.
Just a quick note. So within the report, it talks about the AIRS service being stood down. Yes, within that one, isn't it? Just checking I was on the right report. So I'm primary care hat on. There's a lot of concern about that being stood down. I think the feeling is, although it was funded by the CCG at the time, there is an expectation that actually the communication from patients back to the trust about secondary care needs to be better. And we have found in primary care, since that service has been stood down, that there is an increased workload coming back to us. So my concern is, I know it talks about PALS actually getting more workload, but primary care is also getting more workload, and also the secretaries directly are therefore getting more workload. So I think the report mentions PALS, but actually I think we need to expand that to the influence this is going to have over the system, and that maybe the trust needs to look at a way of not maybe replacing it identically, but better ways for patients to be able to communicate back to the trust. And at the moment, that's simply not there.
I'm happy to respond on that, if I may. Yes, so you're right, the air service was funded for 1 year as a post-pandemic recovery programme. It was a small team of people, and I think the expectation is really that we get back to business as usual in terms of how we communicate. I hear what you're saying. We clearly haven't got back to business as usual, or if business as usual is fit for purpose, then I'm happy to pick any of those issues up with you. I think while we were recovering, we had a lot of churn in terms of booking and cancelling and all sorts of long lived problems that people hadn't been able to resolve over the 2 years of the pandemic. So we're absolutely committed to improving patient communication. That bears through in terms of the complaints we read, the way we sort out individual inquiries, and so happy to pick that up. But the plan is to make business as usual deliver what it needs.
Any other questions or comments? Okay, thank you. Learning from deaths, Q3 report matter.
The report is quite detailed. I can imagine, Jackie, you're going to be telling Matthew to reduce the size of this report.
I won't be telling Matthew, I'll be telling you.
Okay.
Not necessarily.
Okay, no. So it's quite self-explanatory. We've had about 750 deaths in 3 months in Q3, out of which the one that I'm interested in is the 20 nosocomial infections that we've had, which is related to COVID and MRSA. In terms of the quality, so the 2 cases that are particularly important, or we discussed in depth around the preventable or the poor care that we have delivered, is one is a 65-year-old gentleman with sepsis, which I think we could have done many things differently in treating the patient. May not have prevented the death, but we could definitely learn. Part of the improvement work we've done, or we're working with Anne's team around looking at some improvement in sepsis 6 screening, and we've started with KGH-AD, and that has been
has been successfully rolled out, and we've audited some of our data around that. The second review that we did was related to an 84-year-old gentleman, which on retrospect has, we don't think it was poor care. However, it has identified an issue related to a named consultant on the board for each of our patients, and that is a recurring theme that has come across for our inpatient wards, particularly the way we function between the medical model and the specialty model. And Kirsty's here as our junior doctor, who will definitely hold me up if I don't mention that that has been a problem. Our junior doctors have been fantastic in supporting us with that. There are multiple areas in looking at the problems related to care that we've done really well. But the one that we're really struggling in is how do we reshape or refashion our medical intake within the inpatient wards that will have a direct impact on how the mortality or the morbidity of our patients and length of stay of our patients within the ward. And we will be discussing job planning and some lessons that we learned from the junior doctor strike and from some of the reports that we've been seeing over the past year. Been a year now. So that's gone pretty quickly. So the lessons we've learned around the reviews that we've conducted and what needs to change or be different in the way we manage our medical models in the organization. We've had 8 patients with learning disability and 1 autistic patient that we've actually looked at the cause. I think the bit there is a piece of work to be done with medical examiners around what we put in as the cause of death in our death certificates, because we should not be putting learning difficulty or Down syndrome, because that's not a fatal condition in itself. That's it really from me. So happy to take any questions.
Is there a reason why there is a mention of HSMR in the overview?
Yeah.
Is there a reason why we don't include that or more clearly so that the board can be assured that we're within the right areas?
Yeah.
And secondly, well, and this may be happening at quality committee, I don't know. And secondly, the what's it called where you're able to look at individual conditions and see whether or not you've got disproportionate death rates in it? Something. I have in other places seen diagrams which, well, the funnel that I'm interested in, but 2, the thing, sorry, I'm not being very articulate, the thing where if there is a disproportionate number of deaths related to a particular condition, that can be a signal that perhaps that's something where you need to investigate. And usually there isn't a problem, but it prompts a review of those cases.
We're going to look to Kathy.
Yeah.
Yes.
All right, so I'll try and help. So
you know what I'm talking about.
Yeah, there's a couple of different things. One, HSMR, for example, is made up of a basket of conditions, and you can get them for conditions. In other words, you've got to remember that HSMR is it's not a sort of absolute, but it's the 100 is a sort of average.
Yeah.
But you can see that's made up of a set of things, different conditions, and so you can see it for each one.
Yeah.
And then the other thing that happens is if there is an outlier, I think it's CQC that writes and says you've got an outlier here, and you need to look into it. So I think those are the things you're talking about. But my personal view of overseeing this, but also having vast experience in the past, is it is complex because everybody uses a slightly different. There's HSMRs, which doesn't include the out of hospital, that's SHIMI that includes the first 30 days, there's RAMI, there's the head data you'll be familiar with, Jackie, that came from Birmingham. There's a lot of different measures. My personal view is that the numbers you need to keep an eye on them, but really, really what you need to do is look at the learning from this, which is why the 2017 guidance was put in there, was actually what do we learn from each of these and where do we say where we've contributed to the outcome by poor care. I think those are the really big things. There is a bit of things about coding, but I always think coding is a dangerous path to go down. I've probably not helped.
I agree. I absolutely agree that the learning is the important bit. But I have in the past been questioned by CQC about the extent to which the board understood
the HSMR and the shimmy figures.
I completely agree with that, but I'm just putting it in proportion. So I think we should have them visible in somewhere in our IPR or whatever. It needs to be visible because the board needs to know, are we at, usually London trusts are well below 100 for HSMRs for reasons unknown, but we would be very surprised if it went above that.
Okay. Is it about this?
Yes, surprisingly. I do know. Slightly outside. I thought we had a really good discussion actually. And this is really core businesses. This is proper compassionate leadership, etc. I think as we do spend less money in areas we shouldn't, like our framework agency, we're really interested to see how we can improve both the learning and how we wrap around patients, families, etc.
I'm glad you made the point, Jackie, you did, because I was going to ask the question initially around deaths from COVID, whether our percentage of deaths from COVID is what we'd expect it to be, or whether there's any variance, outlier, etc., compared to other areas, and whether there's any information about those who were fully vaccinated or otherwise, or had other long-term conditions that might have had an impact to there. So it's sort of helpful to understand from sort of a board and a community perspective as well, because it's the sort of thing that goes back into boroughs that are interested on. But I think Jackie's point, I just want to underline it's really important for us, the board, to know if we're an outlier on any sort of cause of death, and then the contributing factors to those, because it's those sort of things that you look at as a board for telltale signs that then go on to having further discussions at committee and deep dives, etc., and the exec looks into it. But it's got to be where we triangulate things, isn't it? And so, and quite often here it'll be a judgment that we'll have as opposed to real hard evidence on something. But often that is those sort of asking those questions and being curious is what a good board ought to be. And I think if that can happen without extending the size of the reports, it'll be a much smaller font. That'd be great.
No, I think it's just made me think I should probably go back to look at the Bart's report and see how it's presented there, because I think that would be.
It wasn't Bart's I was talking about.
But you tell me.
Although it is in the Bart's report.
Yeah,
it wasn't Bart's report.
So it's just prompt me to think around that. And I think the information for COVID, you get the trends at the end. You don't get it every 3 months. So at the end of the year, we will know what has happened for the organisation and where we are in terms of variation. So we can come back to that. I think more importantly, we look at this purely from a mortality perspective, but there's a whole patient experience perspective that we don't measure that is interrelated to poor care. But it may be poor care that doesn't lead to death. And I think some of the key pieces of work that we are trying to work with, and we discussed with the board at our exec meeting this week, is particularly how do we capture and measure that. And I think there's a bit of it that would be around death, but there's principally how do we as doctors, or how do we as a team deliver care in this organisation. And I think there's a lot of improvements that needs to be made.
Just to reassure people, we're in the lowest risk banding for our shimmy data, which is a summary of mortality indicators. So we're in banding 3, which is lower than expected compared to the expected number of deaths. So just in context, if anyone's sitting here thinking, I hope there's nothing deeply unpleasant here, I think on both HSMR and shimmy, we do benchmark well. So should in context.
Thank you. Any other questions on this report? No? Okay, good. Thank you. People and culture. We start with the People and Culture Committee report, Leslie.
Yeah, so picking up the issues where we felt we had partial assurance. The first one's the staff survey. We're coming on to a discussion on that next. I won't pick that up in any detail. We looked at the Guardian of Safe Working report, which really links to the issues as well of junior doctors and medical education that we've spoken about here. And whilst we still felt we only had partial assurance, actually we were really pleased to see the progress that MAMTA has been making in terms of engaging and resolving issues. We had felt a little bit at the committee that we basically got the same report each quarter from some really hard working doctors that just told us what was wrong. And then we were going, this is terrible, things are wrong, but nothing ever happened. But MAMTA's really engaged with that. And the report is now much more helpful. So in the report, we are now seeing actions, proposed actions and solutions and resolutions, which feels as though we're beginning to make much more substantial progress in some of those issues. So that was a positive. The other thing where we thought we only had some partial assurance was around the workforce dashboard, but in particular issues around turnover, because we spoke earlier on in the meeting about recruitment and how we were recruiting lots more staff, and that would help us to reduce our reliance on agency and bank staff. But actually there's also the job about retaining the staff that we've got, so we wanted to see some more information in terms of retaining staff. We had a really long and very positive discussion about learning from the ET, which Matthew referred to earlier on in his report, and I know we're going to come on to that later as well. So the one thing I do want to pick is we just had such a great presentation from Kenya and her staff on the early careers framework. And the careers maps, people will know that Kenya, this is kind of the left-hand side of the careers map. This is how do you get to come and work for us. And it's some brilliant work around how we promote careers within our communities, how we raise awareness of work experience for those who we don't hear from very often, early careers, apprenticeship opportunities, people who think it's a hospital unless I'm a doctor on earth, I can't possibly. So lots of outreach work being planned with education providers, schools, colleges, groups, which was just incredibly positive. And you will see at 3.7.35 pledges that we were asked, and we would all be asked to sign up to, which is basically the way in which we can support this work, which I think is hugely important and a really great initiative that some staff are working incredibly hard, linking in now with work that Janine is doing as well, so we can build this into the whole way in which we encourage people to become interested in working for us, and some of the work that Anne's been doing around anchor institutions. This really roots us firmly enough.
Great. Let's use that then once again as an intro to go on to the staff survey results. Janine.
Yes. So I'll take the paper as read, so I won't go into huge detail, but I did want to pull out just a few key points. So overall, this year our staff survey completion rate is down. We had hoped that we would be able to increase it to around 43%, but it's down by 4% to 39%. There's very little statistically significant change across the people plan metrics there, with the exception of We Are a Team, where we did see a statistically significant improvement. Key things that I do want to pull out in looking at variation across the demographic groups. Staff who have disclosed that they have a long-term condition, or that they're lesbian, gay, bisexual, transgender, or queer, or questioning, have a worse experience overall than staff from other groups. So there's some key items there. I think for people with long-term conditions, particularly, they reported feeling less valued within the organisation. And we can talk. I'll talk a little bit about some of what we have planned and in place to try to address that. Bullying and harassment. I think that was touched on earlier on. Overall, within our organisation, staff from both white and Black, Asian, minority ethnic groups reported higher than the national average instances of bullying and harassment from patients, staff, from patients and staff. So that's particularly worrying. Other things to pull out, I'm particularly concerned about the high reporting of burnout and stress, higher than the national average. I think it's very high across the NHS at the moment, but in our organisation it's higher than the national average. 36.7% of our staff reported thinking about leaving, and 30% said that they are looking to leave in the next 12 months. And so with the point that we touched on in the People and Culture Committee report around attrition and that high turnover, there's something there that we need to get ahead of. So thinking about what we're going to be doing about that. So the Ability Not Disability Network have developed a new reasonable adjustment policy, which is going to be really important in encouraging people to not only disclose that they have a disability and require support, but ensure that they're able to achieve that support in a timely way, because I think that's one of the key barriers that staff have reported. In thinking about pay came up, as you'd imagine, a lot, and reward overall. Recognising, obviously, we've had the good news yesterday that we will be looking to progress with the pay uplift for some of our staff, not all, but also recognising that there are other things that we can be doing locally to increase that sense of feeling valued and feeling rewarded. So events like the Long Service Award will go towards that, and there are myriad other things that we are looking at within People in OD to help with cost of living, thinking about adjustments to things like the NHS fleet car scheme, which is particularly helpful in terms of thinking about people who need to drive to work, and the upcoming changes to the ultra low emission zone as well. So further things that we are doing, we've established last month a staff experience steering group, which is going to help to enable the increase in staff voice, and increase the ability for us to share the kind of you said we did. I think what came through is that not everybody is cognizant of all of the great things that we are doing within the organisation to try to address the concerns that staff are raising. And we're also going to be looking at moving forward with more frequent staff surveys. So one of the things that we are doing is introducing a stay survey. Rather than an exit interview, it's a save interview, basically, just to get ahead and understand why people are thinking about leaving the organisation, so we can start to take appropriate action. I think that's the summary there.
Thank you, Janine. Kathy.
Well, thank you for this report. It is one of the most important reports. It feels as though it comes to the board each year, and I know everyone then says, "Oh, it's only once a year and things change." True, things haven't changed, I think I would say here, which you could argue in a very difficult year is actually some comfort that it hasn't got dramatically worse, because I think it has in some organisations. There was one thing that intrigued me, and I'd be interested in your reflections on, and that is that the engagement score, you've got a little table on page 124 of the pack, which has got greens and reds on it. And the bit that intrigued me, that felt out of kilter with all the other bits, was that the BME, actually some of the scores were slightly higher. And so I was intrigued by that and wondered if you had any reflections. But the other thing is, you've got a little table earlier on page 123, which says the things we have been doing. And if I was being really harsh, I'd say, well, we've been doing those, but we've not shifted the dial. So what's the root and branch stuff we're going to do that will be different this year, that we believe will get to the heart of some of this? And then finally, the response rate wasn't where you wanted it to be. Clearly, you've said that, but we're left with 61%. We don't know what they think, or we can surmise what they think. Maybe it's the same.
Do you want me to respond? Yes. So, in looking at that, so I didn't specifically mention that apparent improvement in the BME score, because I think we're doing a further piece of work to drill down into what proportion of our Black, Asian, minority ethnic staff actually completed the survey this year. Because I think, as you rightly point out, not completing it probably says just as much as completing it around the engagement. And so we're taking that as we're not highlighting it as a celebration at this point, because we have other sources of information that speak to the fact that the experience for our Black Asian minority staff is still worse than the experience of our white staff overall. If we pull in the RES data and other sources of information. But the fact that staff have completed it means that we are acting. So that's where I've specifically pulled out the long-term condition and LGBTQ staff group, because clearly there is something there that we do need to be looking at and being really focused on. And in terms of what we're doing, I think part of this is that we are transforming culture. And it's very difficult when you're just taking it as a kind of on a 1 year view to say, yes, this has either worked or it hasn't. And so what we're looking to introduce this year is a series of pulse surveys. So we're looking to have more frequent messaging, plus also the staff voice through the steering group that I mentioned. And in terms of the root and branch work that we're doing, the thing that's come back consistently has been the experience of the immediate line manager. And we'll speak to that later on in private board when we talk about the outcome of the ET. And so we are doing really focused work there. So introducing the manager's license over the next few months, aimed at really improving the skills and capability of our managers so that they can fairly and appropriately manage and support their people. I think the other thing that we're looking at as well is and we have introduced, is the update to the My Conversations piece. Again, improving the ability for people to have conversations about what their development needs are. And also within that, recognising that not everybody feels able to speak openly to their managers about their needs. We've also introduced this year a final page which is private to the individual and is only seen by the people in OD team, that says, I felt able to actually be honest in this conversation. And if they didn't feel able to be honest, we've given them a detail of where they can go to come and talk to us further. So I think we're mobilising a lot off the back of this survey and also off the back of all the other channels of information.
Caroline. Thanks very much for this report. I was wondering, with the data that you've got, you mentioned about bullying and harassment. Have you got any idea of those areas, in order to give you an indication where sort of to dial up things, where there's perhaps been an external impact which has affected things? For example, people working in ED or something like that. Have you got any insights around that, which is then you're able to translate into some of those actions you mentioned?
Yeah. So sitting underneath this overall organisation report, we have individual, what was divisions that now we're reworking it into the clinical groups, which enable us to do detailed action plans. And so we can deep dive if it is ED, we can do quite specific and local action planning to address.
Thank you.
Yesterday, at the Barts board, we had a staff story actually from some of the staff that have been insourced as part of the Serco insourcing. And one of the interesting comments made by the one of the guys that was a security manager was about his sense of responsibility, some training that he'd done, and his sense of responsibility to staff who had faced abuse from either externally or in fact from other staff as well. I wondered how much our security teams feel a sense of responsibility to our staff to protect them, and whether or not there is more that we can do to sort of develop that, because I thought it was really, he was really good in the way in which he described it actually.
I think we talked about security mainly because they might spend on it. Actually, and I think it's, we shouldn't underestimate the amount of grief the staff get from the public. Actually, particularly people who wait a long time in the atrium for services and so on. There's some real flashpoints, and we've helped out with their own security staff this year. At times when they've asked for support around that as well. And I think what I find what's upsetting is when you talk to staff and they just accept it. It's part of their life. They accept the fact that they're going to get grief during the shift. you know, some of the non-white staff accept the fact that there's going to be racist comments made about it. I don't want to be seen by a doctor or whatever, you know, and people have reported these kinds of comments to me. It's things they don't feel they should escalate. They say, well, let's start talking care here and that. And I think that's that creates some of this atmosphere of tension. I think in our experience, the security guards here at the security staff have been really good team to work with, actually. I think they did a lot for us during COVID, well during the pandemic. I think they're a good community bunch, actually. But I thought I was struck by the conversation with the circuit teams yesterday. I've spoken to members of staff here who've worked here for 30 plus years in different kinds of roles, and they've been tupied across external providers at the minute, but they see themselves as part of our trust family, really. And then, you know, Nick and I and Sean and others have been spending a lot more time with Project Code that run the PFI, etc., to think about how, you know, longer term we make sure that that relationship is much quicker, much more much closer rather. But we think longer term about options and sourcing potentially, you know, and there's a paper about that later on. So the security on the whole here, I think, are a good responsive bunch, and I think they take the responsibility very seriously.
Ruth and then Caroline. So something about the report that kind of struck me was there was some of the outcomes that I felt were quite conflicting. That they would say, yes, I can go to my manager anytime, and I felt listened to, and then in other ways didn't feel supported by their manager, which kind of brought to me of, have we really let our employees understand the expectations from both sides? Because if you don't get that right, then it almost feels like they're never going to be content. They're never going to be happy because actually they don't know what to expect. And sometimes they expect too much. And then like the abuse, I think they expect too little and they should have more support there. The other thing, I wish they'd never put pay in these questionnaires, because anyone that is happy with their pay and says that they are maybe be paid too much, it doesn't seem a helpful thing to ever put in. And I think also then all often
Not least as we don't have any responsibility for it.
Yeah, if it's set, it's set. But again, that goes back to expectations, doesn't it? And also for people to realise what they receive isn't what the trust pays. So the on costs on top of this, and that pay hasn't necessarily come down in the block contracts. That it's not, like you say, a lack of wanting, is it, to do it? But sometimes our hands are tied, but we recognise that.
Leslie, and then oh, sorry, Caroline, and then
No, Leslie, you go first. I think there's something about people who don't respond to surveys often don't respond to surveys because they think there's no point. So I do think what you've said about the you said we did is really important in terms of making people feel that their voice has been heard and that we might be able to work to get the numbers up. And I think the pulse surveys will be hugely important in that, because we can't just wait another year to find that the dial hasn't shifted at all. We need regularly throughout the year to know whether we're making progress. As you say, we're doing a lot, but we need to see whether it's having an impact. And if it isn't having an impact, then we need to do something else, or we need to tell people a bit louder what we're doing. So I think that's important. You talked about doing the planning at a clinical group level. Are we, through your team, having some oversight of what those plans are? Because I think there's a lot to be said for having plans at a local level, but there is also something about being able to quality assure the plans that people are coming up with, to make sure that those plans do cover what we think they need, but also to pull out any themes that everybody's got. So we're doing something at once rather than doing them half a dozen times slightly differently in half a dozen different bits of the organisation. It's perhaps not as effective. And I do think, and I did the same at Barts, we did the same thing yesterday, the numbers of people saying they would leave, I think is just worrying in general in the health service at the moment. And I absolutely hear what you say about pay. And, you know, asking anybody who works in the health service at the moment, it's just like most people think, why are they striking? Because they're not happy with their pay, and that's obvious. But I do think there's something slightly more than that, and that was talking to staff at Barts yesterday when we talked to staff here. And I don't think it's by us necessarily. I think people who work in health simply don't feel valued at the moment. And I don't think they feel valued by the government. And I think they, you know, an unwillingness to even negotiate is taken as a, you don't care. We worked really hard during COVID. We haven't had a break since. You won't even talk to us about the fact that we ought to be paid more, and you don't value us. So I think there's something, you know, the more we do, even if it's only at our very local level, the long service awards, the other things we do to just show staff that they're valued. Because I just think people feel completely unloved and unvalued in health at the moment. A lot of which is not anything to do with us, but that's the environment we. Matthew.
Yeah, we've got another sort of thank you event coming up in July as well. And I think we're having, you know, last year I think some of the staff approached with some scepticism, but I'm really impressed by how great it was actually. And I think that having gone out to people who are offering breakfast, lunches, and even a family day on a Saturday, we've had really good numbers signing up for that already actually. And I think word's got around it. It was a really valued event actually that did show we care about it. So we're expecting some of this year. I'd encourage, I don't think many of us got along to it last year, but it'd be great to see the sort of nights and the execs out force at it this year because it's a fantastic event. But that's the kind of one-off thing. Actually, there's a more sustainable issue, which is about what it's like to come to work here at the minute. And actually, the NHS as an employer is in a position at the minute where because there's a workforce shortage nationally, other industries are attracting people away from the NHS, both within health and other services. And people are comparing us as an employer to where their friends are working. And I think some of the conditions, we ask people to work in issues like IT systems, like break rooms, like a different office space. It contrasts quite dramatically now with what people are able to find in other sectors. When you see employers in the retail industry offering really big packages to get people in on really attractive terms and conditions, there's a question for us not just about how are we a good NHS trusted employer, how are we a good employer that benchmarks against all these other sectors people can decide to move into if they've got good skill set.
Catherine and then Mark.
Thanks. I think earlier on you mentioned about the coronation event, and I absolutely acknowledge that not everybody is a royalist, but I don't think because actually quite a lot of the anti-royalists are having great fun too in the royalists. So I think the merge actually helped funny actually. But
Did it stop you sitting on a throne?
it didn't. We had all standing and pretending to be Camilla. So photos to be shared later.
There are photographs.
Yes, there's several photos. But the reason I raise that is because the amount of energy that's generated in terms of people on the wards, the level of excitement about actually senior teams going onto the ward there. So people were delighted to see Jackie, delighted to see me. And I think we shouldn't underestimate when people look up, they really do see us as very important people and really do value us going to the ward. So I think it might seem really boring and really tedious to do this stuff, but it is really important. I think it makes a huge difference because they are waiting for it. They're coming. So do a few more walkabouts, I suppose is what I'm saying. But the other thing is, all joking aside, we have got the 75th celebration coming up that I know I keep going on about, but it is really important. And nearly half the tickets have gone for the Saturday, and 3/4 of the tickets, we've got 400 tickets left on Friday night out of 1,200. The tickets have been on sale for 10 days. I think that tells a picture, a story of people wanting to go. Obviously, the band is an enormous draw, I have to say that. But the afternoon tea, the lunches, they're not quite as but they're about. So people are wanting to come. So I think if people can come and help and host a table, it's not difficult. You know, make sure people have cups of tea and things. But I need quite a lot of help. It's 4 days. It's quite a lot of help. And in all honesty, I sent out an email and 3 people have responded to saying they'd come and help. So I would be really grateful if people could look at their diaries and let me know, because we're trying to plan around who's coming and who can come and help. And I think you are really, really valued. We are really, really valued as a group of individuals in this organisation. And just being able to sit at a table with chief and other is really meaningful for lots of people.
And what's more, Matthew and Alan's band will be playing again.
It's awesome.
At lunch and dinner.
Never stop.
Protect your voice.
Mark.
Yeah, so I think one thing we've had with you
said we did is you said we did in this room is fine. It's whether it cascades outward. So the number of times, you know, I will go somewhere on a visit inside the university and someone will say, but you haven't mended this. And I said, but you do know we're spending £2 million on this building next month. I said, really? I had no clue. So you said we did works only if there is a radial mechanism for it to radiate throughout the organisation. And otherwise, what happens, it's certainly in my organisation, is it gets stuck in the middle management. And people say, well, everyone knows about that, so we don't need to say anything about it. But in fact, you need to say these things. And actually, you need to say them frequently and often, and sometimes the same thing to make sure that it lands, because not everybody receives the same messages. The other thing, to your point, Catherine, is it is important not to underestimate managing by walking about. Because when you walk about, people tell you things that they won't tell you any other way. Or they'll come up to you and say, could I just mention something? And I think that many organisations, and this includes mine, are experiencing staff dissatisfaction because they've been through a very difficult period. And it's, as you said a moment ago, just having a few claps doesn't pay the bills, really. And people are feeling really under pressure. But because of the spirit in the NHS, that can't be completely corrected because it's at the national level. But you can correct it a lot locally by simply being much nicer to everyone. And you know, I know that sounds all obvious and simple, but sometimes, as you said a moment ago, people see people like us who sit in rooms like this as too important to care about what goes on. But they actually, if they were all sitting in here with us, they would be quite surprised at what we're talking about and how much we all care about it. But I'm not sure we're as good at radiating that as a community. And I think in the NHS, we tend to have this stiff upper lip, let's just get on with it. Let's soak up the abuse and not worry about it. I think we do in this post-COVID period have to look after people a lot more.
Caroline. I'd like to pick up actually from something you said, Matthew, around the security guards, because when I was coming in this morning, I saw one of the security guards dealing very sensitively with a member of the public who was distressed and having other issues and things. And I was wondering if that might be an opportunity with the leadership programme work, that using some people like security guards, people who may not have a voice on or go on those leadership programs, but other people could learn so much from them. I mean, that sense of responsibility, I wish I could bottle that and give that to some of the leaders I work with. It was, amazing. The one that you mentioned, Matthew, having him speak to a group of leaders about his sense of responsibility and ownership. So that might be something to think. Kathy.
Just a quick one to pick up on this communication that sort of Mark was talking about as well, is I think we should remember, well, I hope we're remembering, not everybody has access to computers, actually. There's quite a lot of staff who don't, do they? And I think, have we got all of that covered? Are we doing Team Cascade or anything where we actually talk to people? And then the other thing is, there is a risk of raising an expectation because you've been and heard and nothing happened. And they don't hear it connects back to them. I think that's really tricky, but I think we just have to remember all of that. And then a really practical note, if Catherine, I'm really sorry I've not responded about the date, but I just wondered
I wasn't telling you off, I was just mentioning it.
If you could send round what you would like us to do, ask, that would be really helpful.
Peter, is this an opportunity for you to talk about workplace?
It can be, yeah. I mean, it is.
You usually like the opportunity to talk about workplace.
I mean, usually if workplaces can be on this.
Yes, absolutely. I have it.
And thankfully everyone does have this. Challenge remains, sorry Nick, for people say they can't mess with the Wi-Fi and all of it. As we know from Nick, 2 days, sorry, 2 years. And that will improve that. But I think the crucial thing that Mark mentioned is it's a problem in this organisation. I'm sure it's a problem in lots of other organisations. It's getting that bit in the middle to start doing the up and down. That's been consistently the challenge of this organisation for the years I've been. But I think that the senior leadership changes that we're putting in place in the meetings. Janine and Matthew are running every month. We were talking, weren't we, as an executive and leadership team, that we would start having key messages at those meetings. The point you make, Mark, Matthew, sometimes people don't know the basic facts about what RED is. Trying to get shared ownership about organisation. Key point, as you said, Mark, is repeat it once, repeat it 10,000 times.
Janine, is there anything you want to wrap up with?
No, I think I've been mining you all for your wonderful ideas. And Leslie's just suggested let's stick things behind the toilet doors. So we'll be we'll be looking at that closely. Everyone has a wing. Yeah, behind the blue door. Oldie but goodie. So yeah, thank you.
Thanks very much. Finance and operational performance. Start with the committee report, Mabu.
Yeah, thanks, Becky. Thank you to Linda and colleagues for the report and format it is, and for everyone else who comes to the committee with their reports, their papers, and their contributions. Just thought I'd say that because I've been chaired for just over a year and been impressed by what we do there. Board assurance, we give it partial because Matthew was going to go and have further words at the ICB around help. Could have given it assurance as well because we know that's going to be a long running saga anyway on that. There's three sort of partial assurances all in a row that relate to sort of workforce and spend on non-permanent staff, and our target for the year was to try and eat into the £25 million target. We were still left with 18.2 million short on it, regardless of trying really hard. And I think the points that colleagues have made around staffing are really relevant to this, and what we see generally in our ICS area, which I wasn't aware until Matthew mentioned it earlier, that where the highest users of non-permanent staff, and there obviously there are reasons that we need to try and get further underneath that to understand it on there. But it is probably the single most biggest risk for us going forward into next year's plans as well. On the integrated performance report, it's partial assurance because of what we discussed earlier around the increase in waiting lists, but also worth mentioning that our performance on cancer is the second best nationally. So huge credit to everyone involved in making that happen. And it does show that that we're a trust that has got some real nuggets of fantastic performance, which many of us would have seen when we went out on the ward visit or to the visits this morning, the governance visits, that it is that whilst there's always things that we need to fix, it is a great place as well. On finance report, we'll be covering that later, so I don't want to say much on it except for to say that we're keeping a close eye on cash. Cash is better now than it was 3 months ago. That's good, but it's a risk going forward, and keep on watching that very carefully. Just want to make two other points, and then I'll stop because this is a segue into the next report. One is that Mike represented us really well in discussions with the national team and as part of the ICS negotiations on finance, where we get to. So thank you very much, Mike, on that. And regardless of your coloured shoes this morning that I mentioned, I'm sure they didn't see your shoes, but it was you. Thank you for stepping up.
Your shoes.
Bullying embarrassment, you know.
It is. It is. I got Mickey taken out and back. My socks this morning. First thing, somebody walked in. It was really refreshing to have at the committee senior colleagues who deliver services talking about surgery, critical care, anaesthetics, women and child health. it sort of brings it to life and makes it real. But all of the finance discussion, the staffing discussion, performance that we have, to hear from them about how they're translating the high level plans and taking a sort of grassroots bottom up approach to bringing them together, and very importantly the benefits for the patients that we serve and the challenges that they have and how collectively they work to try and overcome those. And if we could give that bit of the committee meeting a rating, what you could go beyond green, whatever colour it is, about the level of professionalism, enthusiasm and commitment to the organisation. And it's something that we're going to continue doing each meeting. And they agreed to come back in 6 months for a follow-up to let us know how the plans that they shared with us have turned, how they've implemented them, and what challenges they faced in doing that, and how they've overcome those. So it's about it from me. Let's finish on a sort of a high note of positivity about those great staff who came to the meeting.
Thank you. So let's use that then to move on to the integrated performance report. Caroline, are you?
That's me, and I'll start off and then Fiona will pick up on the elective side.
Lovely.
So on the unplanned care side, type 1 performance in March was 34.88%, which is 3% higher than it was in March 2022. Conversely, from a type 3 performance perspective, which is the performance of our UTC provider, which is PAL, that was 70% in March, which is almost 20% worse than it was in February 2022. So it's a significant drop off by PALC over the last year. So that means our all type performance was 56.5%, which is 6% worse than February last year, but with the adverse effect of that, of the PALC deterioration within that number. So I'll just talk a little bit about what we're doing to correct that, and we talked about the trajectory for all types of performance at the last meeting. So our SDEC has opened at Queen's, so that opened mid-April, affectionately known as Big SDEC. It's now double the amount of space that it was, and we've changed the pathways out of ED and into SDEC considerably. We are going to replicate that work over at KGA, and we're working with the team over there to do exactly the same thing and learning some of the lessons of the work we've done here. We also have the modular build that is now complete, and we're looking for investment in staffing to make sure that we can use that over the next few months, and we're working through that. And we're also looking at how we use our assessment units far more effectively. So whilst it may seem that we're having a slower than maybe we'd like improvement, I think it's sustainability in that improvement that's the most important thing, making sure that we deliver constant change, and that we make this as that we make it stick basically over the next few months. So happy to take any questions, but Fiona, do you want to do your elective? Shall I go next? Or yeah.
Yes.
Is that okay?
Yeah.
Okay. Well, I feel like Matthew's stolen my thunder on elective, so I'll try and be brief. Waiting list, as we said earlier, hovering around 65,000 pathways, and obviously turning that around and getting back on track with regard to waiting list reduction is priority for the team. Long waiters, 52 weeks and over, staying around about 1,000. We've had huge challenges, obviously, with strikes and other bank holidays and other events that have really made a difference to how much work we can do. But we are on track for some steady reduction in the long waiting position. Our shift over the coming year will be to look at outpatient productivity, how many patients are waiting for outpatient care or ambulatory care, non-admitted care. And so while we've been spending a whole lot of time this year looking at theatre utilisation, sessional and in-time utilisation, which continues to be high, we're going to shift our focus and start looking at of the rooms we've got, how many of them are we using, and are we using to the best use? And secondly, as per the national programme, is the work we're doing in the appropriate for the needs of our patients, And are there improved pathways that we can adopt and implement to get patients seen quicker, care delivered faster, and discharges back to community and primary care in a more appropriate way? So a good year, it's a sort of year-end report, but lots and lots of work to do going forward. Key areas of risk remain in outpatients around specialist medicine, again, very outpatient-based services. And gynae, I was just going to mention very briefly the disproportionate impact on gynae services when there was a junior doctor strike. To keep maternity safe, we took everything down. Almost every planned event in gynecology was taken down because we had to move senior consultants into maternity. So, disproportionate impact on services, but for some services, a real problem in regards to maintaining activity. I'll touch briefly on the DMO1 position, which I think we all know is now very stable, delivering a really good position. We're around hovering around 97%. The standard is 95%, so that's a really great place for us to be in. And we keep up the good work with the radiology team and some of the other services, and a really close eye on maintaining and managing that PTL. It's high volume, rapid turnaround work. It never ends in that arena. And finally, on cancer, grateful to Mabu for mentioning that we're second best nationally, but actually I just wanted to clarify one thing about that. We are the second best in terms of recovering from a backlog in the cancer PTL. So what that really means is that we've been focusing our efforts on navigating and designing investigations and care for patients that have been on PTL for too long. That's the nuts and bolts about it. Our first point of access, 2-week wait, is compliant, which is great. We're keeping up with demand that's coming from primary care. The FDS standard has been affected in some part by the radiology backlog, which we've already heard about, is now completely gone, and we're now into business as usual turnaround times, but also the sort of side issue of histopathology staff and turnaround times there, which seems to appear in lots of reports these days. So we are looking at that, and we are working with the Cancer Alliance to improve the capacity there. And fundamentally, all of those actions will add up to a better position on 62 days. That's the real measure of cancer care, is are we diagnosing and treating patients with cancer quickly enough? And the answer at the moment is no, but we are certainly on the road to recovery. As I said, we're second best in the country in terms of recovery, and we're now 69% against an 85% standard. So more to do, but lots and lots of good work going on. And I chaired Cancer Board this morning, so very detailed review was had this morning. Thank you.
Thank you. Questions or comments? Mark?
It's a big thing in a country that doesn't have great cancer outcomes to have the second lowest cancer outcomes. I think you should paint it on the walls. Honestly, it's a big achievement, especially if you think about deprivation scores or the areas you're operating in, which almost guarantees relatively late presentation, which is not easy to rescue.
Answer.
Thank you very much for the report. I actually feel reports in this area are getting much more positive since I've joined the board, so that's very, very welcome.
I think you should take the credit for that, Mark.
The opening of the new same-day treatment centre is great news. I'm just wondering if that's actually going to end up masking the performance of PELC. Or are we still going to be able to see that separately and not have that covered up, because there remains an issue in that area that we mustn't let go of. Thank you.
Do you want to respond to that point, Caroline?
So I think that we are helping PELC as much as we possibly can. So we're helping them to reorganise how we screen patients at the front door. We're helping them to we're giving them extra space if they need it. So we're doing as much as we possibly can to help PELC.
I don't think I don't think masking the issue, I don't think we'll mask the issue. But I think that working together with them, even though it's not contractually our service, we have limited levers to pull with them, that we work on the ground day to day, we work with them constantly. And I think that's the best way. That's the best way to approach it in the absence of any commissioning decisions that may be taken by the ICB.
I mean, thank you for that. I think my concern is, and it's good to hear the collaborative working, and I'm not denying that at all, and I think we should be doing that. But the fundamental issue about their performance doesn't go away, and that's the bit I'm worried about. So that if all we're doing, while it is contributing to a better patient experience that comes through our front door, fundamentally, until that particular service is resolved, we're actually, as they say, pushing a snowball uphill.
Matthew.
Yeah, I mean, we've arranged now for, I think Jackie, I think Shane and I are going to meet Marie Gabriel and Zena Etheridge, who are the chair and chief exec of the North East London Integrated Care Board, and to talk about the front door model here as well, because I think, you know, the teams on the ground are working hard. The PELT team, Steve Ruby and others are really important partnerships to try and deliver their capacity to deliver that existing model. As I've said publicly before, I don't think that model can be sustainable delivered here. I think, you know, our type 1 performance, I think when you see the April and May data, I think you'll see we're making significant strides in that actually. I think though there's still a clear disparity between a type 3 performance level of around 70% and the next level in the country, I think, which is around 89–90%. And I think in Barts you'd always expect some to begin with a 9 by and large, around that as well. And that does affect the whole pathway, because 5 out of 6 of our patients who come into us for emergency treatment come via PELC. So the people who come into the emergency department have been through that PELC pathway, and we're trying to get some data at the moment on how long we spent in PELC before they go through there, because if they're coming through after 15 minutes, then there's a good chance for us to see them treatment in 4 hours. If they're coming through after 3.5 hours, then zero chance of doing that, and also the patient experience, and then everything to do with the abuse and the stress in that environment.
Ruth. So I was kind of going to comment on that too. So I think clinically, STEC doesn't mask anything. Actually, all it does is get the patients to the right place quicker by enabling the streaming to be more effective, which, yes, I think helps PELC, but I think appropriately helps PELC. And that's our responsibility, really, to take those patients on. So I don't think that masks that. I think PELC is another whole world of issues, but I don't think that's one of them. Very much welcome the focus on outpatients. But I do think we also need to push this to an end, a kind of more of a system look at place, because if we are struggling in our own estate to hold outpatients, then we need to look at our partners to go, where else can we hold these? But also the real key thing, which is yours, Nick, of the digital strategy moving forward, will certainly help us deliver so much more of outpatients. And what I don't think I've got a grasp of yet is, yes, we've got X number on our waiting list to be seen in outpatients. How many of those are going to convert to surgical treatments that have just yet to be decided? I don't feel like we've got a feel of that really yet, and that's going to be really important so we can project that onto activity for the following year.
I'm happy to sort of, so the vast majority, the biggest waiting list we've got is gynae. Okay, and the conversion rate in gynae is probably less than 15%. Okay, so the rest of the big areas around outpatients are non-surgical specialties. There'll be neurology and all of these sort of specialist medicine services. However, we work on a base, so at the moment, of 65,000 pathways, 5,000 are admitted. So, I mean, that's very, very low ratio in terms of conversion of the current PTL. And actually probably slightly inflated because we had a backlog of admitted as well during the pandemic. So I'm confident that we're not going to convert lots and lots of this work into admitted and then fall over because we haven't got the capacity. But you're right about where else are we working. We have been already to visit to community facilities, primary care actually, where we could co-locate services. And Nick doesn't know this yet, but we'll be putting together a paper for some place-based expansion, which will be appropriate. On top of that, you know, we really welcome the St George's development, both in terms of wellness and prevention, but not just that. How do we co-provide services that change the way we deliver services in the acute sector? So there's some transformation stuff coming up, which is really exciting. It will have the acute pathways too, because prevention and wellness is key. But secondly, sort of co-designed, co-produced service models will hopefully reduce the burden on coming to Queen's for an outpatient appointment. So I think if I may, I'd like to sort of bring a much more detailed proposal around where we're going with non-admitted care, because there's lots to do, and it's not just let's find loads more rooms and do loads more work. It's that now, but it will metamorphosize into other things.
Is it on this one?
No.
I've got Kathy as well. Yeah.
Yeah, thank you very much. There's a lot in this report, isn't there? There's a lot of graphs and so on. And some of it strikes me is quite interesting, slightly overwhelming, but quite interesting. There are a couple of, yes, a couple of things I just wanted to pull out that I think we don't spend a lot of time usually talking about. And maybe what you were just talking about was part of it. But if you look at the A&E data in terms of those who are non-admitted, if you look at the totality of the numbers who breached 4 hours, which I don't think is the PELT patients. I think this is type 1s. It says type 1. If we fixed that, the non-admitted, so in other words, the excuse isn't we're waiting for a bed because they're actually going to go home. That would go quite a long way to bridging the gap between 60% and 76%. Not all the way, but quite a long way. That's one observation, and I just wonder how we're focusing on that group, turning them around quite quickly. And the other is if you go down to the graphs, the genuine SPC charts here, in which it looks at the total time in the emergency departments. And it is quite striking. It's on slide 153. There's average time in the department type 1, 502 minutes, 582 minutes. And the little graph shows that for some months it has actually, you know, the dots have lined up that has been a special cause variation actually there. And 4 hours, if my maths is right, is 240 minutes. So that's a lot of minutes. And then the number over 12 hours. And I just think those are kind of useful things to sort of see, we'd want to see going the other way, because that's a lot of patient experience, potential harm time, which, you know, doesn't always jump out. But just thought I'd mention those two couple of areas really.
Yeah, I will. So in terms of the our SDEC development, so what we've done is we know that we're keeping patients in ED for far too long, but the logjam effect meant that unless we had external flow, we weren't getting very far. So by doubling the capacity of SDEC, what we've done is we're moving those patients out of ED far more quickly than we've done in the past.
We should see the benefit coming around as a consequence of that. Okay, cool.
So we saw a big improvement of the first week that we opened SDEC, because those patients that didn't need to be admitted but did need to stay for longer than 4 hours were moved into SDEC and will be being dealt with far more quickly. So that's what's happening at the moment, is we're refining those pathways. And so as when we went on our walkabout, for example, we were talking about how we could have direct to SDEC pathways for some GP patients.
So that should be quite a nice graph to watch.
Yeah, it's a really good indicator.
Matthew.
Okay, my point was more broadly with the pathways that Fiona's talking about. They're pathways that are relatively entirely within our ability, because the patients are referred into us for diagnosis and assessment and treatment, and actually we do control most elements of those pathways actually, and I think operationally we managed to get some really good grip on them over the course of the last year. I think that the space that Caroline's working in is much less within our gift. So when you look at total time in the department, that's total time from patient's registration at arrival at one or two of our sites. So that includes all the time in the different parts of the pathway, including the time we spent in the UTC prior to assessment and transfer around to us as well. So there's quite a lot of different parts to that as well. And I suppose it's the contrast between, and I think what we will see, and you certainly will see when you get ACON, I think May's data points, that these things are moving in the right. And when I see 3 months worth of data like that, then you start to feel you're onto something. You know, 1 month can be all kinds of things, but 3 months you start to feel a bit happy about it. Well, I'm sure there's better SPC explanations of it than that. But I think I suppose the thing for me is to emphasise that I hope the board can have some confidence that we can get this stuff done. The less it's within our gift, the harder it is to do. And there's still a lot we can do on admitted and non-admitted patients as well within our gift, for example, investing, etc. I suppose it's just in terms of assurance that operationally, I think we've put a team together that knows what it's doing, and that we are starting to see things starting to move in the right direction, actually. And it's important for us to address the UEC issue in those ways because it affects people's perception and trust, it affects our staff's confidence in whether they recommend our care to their family and friends and so on. But I think we're starting to see across the board now stuff starting to inch in the right direction at different paces, depending on how much it's within our control.
Okay, finance report, Mike.
Yeah, thanks. Just keep it very brief, I think, because we talk about obviously the year that's gone, but we hit our key numbers, which is great. So we were forecasting 14.5 million deficit. We hit 14.5 million deficit. Just before my computer died, I was having a quick look at where we were in August. And we weren't on track for 14.5. We were probably on track for about 40. So a really good second half of the year. We were really focused on elective recovery. We've just heard from Fiona how we've had consistent improvement in the use of capacity and what that's doing for treatment numbers. So that's good foundations for next year. On the temporary staffing, we've seen some really good progress in medics, which is challenging in nursing, but we've got some good plans around the off-prem, particularly for the early part of next year, so this year now. So good foundations. In terms of capital, we have used all of our capital funding from North East London, which is really good. Took a very busy shopping list in March to get that done, but we hit the numbers. Some underspend against our national programme capital, largely to do with the CDC, which was always very, very ambitious and necessarily so to get the access to the funding. So that will roll over in terms of a programme we've got delivered into 23-24. Yes. And on cash, it looks relatively healthy again compared to where we were last year. So decent place to go into the new year, and we'll see later on, as long as we deliver the plan in 23-24, cash should be okay. So end of the year pretty well. So success, I would say.
Any questions or comments? I will just say, Mike, that that graph that we looked at earlier on in the year, when you had, there we go, where you had the red and the amber and the green, I had negligible confidence. The fact that you have done suggests both some long-term strategic, very important grip, which has been provided, and also some
prudent year end.
That's the one that I was thinking of. Prudent year-end management. Yeah. Well done.
I think 12 does tend to up the trend.
Okay, Audit and Risk Assurance Committee report. Sue?
Thank you very much. So I'll assume the report is read. We have a large number of areas of assurance. The one area, partial assurance, relates to the planning work around the external audit. We are now clearly slap bang in the middle of audit season. And at the time of the committee, whilst there was evidently a large amount of planning and preparation going on both sides within the trust and within our external auditors, I think we felt we needed a bit more join up of the points on the plan and some specifics about milestones so that we could assess progress. Some good reports from our internal auditors, significant assurance on the report on the BAF, good work from our counter fraud team. We are now waiting receipt of our year-end reports. Our internal audit opinion will come at the next meeting, and our functional, whatever it's called, for counter fraud return will be done. All these jargon terms, but generally a good meeting. But we are now absolutely focused on external audit and all that comes with it. So I think that will be the next couple of months' focus. One item required escalation from the audit committee, which was to seek ratification of the use of the trust seal, which is the next item on the agenda. That's all I wanted to highlight. Thank you.
Okay, thank you, Sue. Which takes us to the ratification of the use of the trust seal. Everybody happy? Good, thank you. Right, risks identified during the meeting, I think with the possible exception of some of the stuff, now actually the stuff we talked about in the staff survey is pretty well represented. Anyway, okay. Which brings us to any other business? Mark.
Sorry, Jackie, I said earlier that Matthew should paint on the walls the cancer outcomes. Don't paint them on the walls. This is a PFI hospital. Finally, finally, put them on the edge of the car park, wherever the PFI ends. But just to go back to something that we did a few days, it was a pleasure to welcome colleagues from BHRUT, Cross King George's and Queen's to the opening of our new campus at Linton House, which we should pay huge tribute to Leslie because she basically got it for us. We wanted to have a base here closer to where about 50 medical students are taught at any one time somewhere in BHRUT. And so we've taken a floor there. You're all welcome to visit. We can set up a visit if you want to come. And we've agreed on Tuesday that space can be available for BHRUT educational meetings should you wish to. There's a clinical skills lab there with OSCE stations. There's virtual reality goggles, which no one's broken yet. Usually they get broken within about 15 minutes, but they're not broken yet so far. And there's quite big seminar space and open plan space. It's quite nice. Linton House is a Redbridge building, so it's open till 9 p.m. at night. And so it can be used in the evening for the outreach activities you reported earlier in the board for schools and other things. If you want to bring them there, that's fine.
That's brilliant, Mark. I'm sorry I couldn't make the opening, but that is a really encouraging development. So thank you to you and
great views from the top, by the way.
Fantastic.
If you want to see London. But you can also see the Essex countryside, so it's very nice. That's a better view.
And there's opportunity for a lot more space there.
Yes, there is in that same building.
And this is the time we tell Nick we want space for the
I've already
clinical
told him,
research unit.
I went through the page.
Right, okay, we haven't finished yet. Anything on? We'll talk about meeting effectiveness when we get to the private board. But we have questions from the public. Andy, I think you've got a couple of questions you want to fire away.
Yes, Chair. First off, do you mind if I stand with my phone, which is on Facebook Live, so that often what Matthew says is gets a few views on Twitter because what he says is important. Is that
indeed it is? Yeah, fire away. Yeah, that's fine.
Great, thank you very much. First off, Matthew, the London plan. There's a plan for a big expansion of the London population. A lot of it on the Crossrail corridor, right beside busy roads, or obviously beside Crossrail, which is a health hazard. I've been in a tussle with the Information Commissioner about health stats here relating to air pollution. So I've shifted position. The courts are saying I can't have the stats, which I think would be helpful to measure with the effectiveness of air filters that are being based on these developments. They're saying that it's safe to build in these toxic locations because of the air filters. So I've changed tack to say that it should follow the example of the Fire Brigade Union, and the stats should be given to a third party, a trusted academic, rather than myself. So that's the first question, Matthew, whether you'd be sympathetic or consider that idea.
Matthew, you're talking about Andy, aren't you?
the extent to which air pollution is a contributory factor to child deaths and hospital admissions. Those are the statistics that you're talking about.
Yes, that's correct.
Right.
I've been given stats, but you won't give me the full postcode. I'm arguing that the full postcode is necessary because at the minute, these developments are going ahead. My expectation based on research that's out there, if we know the number of deaths and admissions, and academic will find it's a stupid place to
Matthew
build.
will respond.
Thanks, Mr. Rocker. So I understand that there have been FOIs submitted on this, and that is still within the FOI process as well. But I'm very happy to have a look at how we've approached that FOI, just to see if there's anything within that could help any further with that. So, but there is an FOI process on the way for that, and we'll have another review of how we've responded to that so far.
Thank you very much. On the second point, I'm part of a team. We've been campaigning for a new wing at King George for years. The lack of capacity at this hospital comes up time and time again. So ahead of the meeting, I mean, it's a very broad brush estimate, but in an ideal world, to achieve the 95% A&E targets, which many years ago this trust did hit or has hit, how many extra staff and how many extra beds would BHRU
But anyway, Caroline is going to respond.
Yeah, so I think what we've talked about today is how to improve some of the pathways internally first before we look at building any more beds. So at the moment, we have no plan to build any more extra facilities.
Thank you very much.
Okay, thank you, everybody. We will commence the part 2 board at 3:15. Thank you for that. Thank you.